بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. I'm Ibrahim Mahmoud, infectious disease consultant in King Faisal Specialist Hospital in Medina. Thank you very much for your attendance. In the next 1 hour, we'll be talking about Staph aureus bacteremia. I was given those objectives to include in my talk, which are related to the importance of Staph aureus bacteremia, gaps in the management, difficult cases of Staph aureus bacteremia, and how they were managed from my own approach. However, from my perspective, I want to be concise, up to the point, and I want to give you the clinical approach how to manage Staph aureus bacteremia. I have no conflict of interest to disclose, but I believe MRSA is more interesting than MSSA, and definitely I cannot review the whole evidence and all details related to all evidence. All of the evidence has been in this presentation was based on the PubMed search that was done earlier on May this year. For the sake of clarity and simplicity, I will divide this talk into three parts, starting from introduction, where I will talk generally about Staph aureus bacteremia, epidemiology, difference between MSSA and MRSA, some of the difficult cases. Then I will move to what are the available therapy, the available treatment option, how did we define the standard of care, and what are the other possible treatment option. Lastly, I will go with my approach, which I would think that I would be more in favor of having combination therapy, particularly for complicated MRSA bacteremia. So let's start from the introduction. So Staph aureus bacteremia is one of the most morbid infectious syndrome, and it has been highly fatal. The fatality rate can reach up to 25 to 30%. If you are concerned regarding numbers, the population incidence range between 10 to 30 per 100,000 person per year. The whole story of significance of Staph aureus bacteremia goes back into 1941, where this case report of 122 cases of Staph aureus bacteremia showed a mortality of 82%. Source and pathogenesis, as you know, Staph aureus is a colonizer of mucous membrane and gastrointestinal tract. Nasal carriage is the most common. There are certain risks which increase this possibility of having nasal carriage of Staph aureus, which is mainly healthcare exposure and other risk factors. As you know, colonization translates into risk of infection, and that is applicable for Staph aureus. This is very amazing review, trying to answer a lot of questions related to Staph aureus. But our question here, if you are seeing a patient with Staph aureus bacteremia, what is the source of this bacteremia? Which is probably one of the first questions that you would ask. Unfortunately, the pointer is not working on it. Yeah. So here you can see the list of the listed possible sources for Staph aureus bacteremia, starting from probably the most serious one, infective endocarditis, osteoarticular, skin soft tissue infection, pleuropulmonary, line-related. Sometimes you don't find a focus for infection and other possible infection. Also here they are listed the percentage of MRSA in their cohort and the percentage of healthcare acquisition. If you can just see all the numbers, you will see definitely a significant variation in the percentage. But I will take Australia for example, because it has the largest number of cases of more than 7,000 cases, where the MRSA was around 1/4 of the cases, and the most common source of infection was line-related and skin soft tissue infection. There was no focus of infection in 15% of the cases, and infective endocarditis was only 6% in their cohort. What are the risk factors? Again, colonization definitely is a primary source, but also there has been other diagnoses which is associated with Staph aureus bacteremia, including cellulitis, presence of central line, and being immunocompromised. But also there are certain patient group which has higher risk of developing Staph aureus bacteremia, including diabetic and patient on renal hemodialysis. So Staph aureus bacteremia is responsible for diverse burden of human diseases, but our focus for today is the bacteremia, which is common, highly fatal, And the Staph aureus affinity to have foreign material and to attach to it definitely poses a problematic dealing with prosthetic bone and joint infection or endocarditis. Reflecting into our local data, this is the largest report of Staph aureus bacteremia. It was done from National Guard Hospital in Riyadh. 633 Staph aureus bacteremia. 1/3 of them were MRSA, 1/3 was related to endocarditis, and the mortality actually correlate with what is reported in the literature, around 20%. What about MSSA versus MRSA? Because we get the impression that here we get less MRSA compared to the West. Actually, this is the antibiogram that was published from King Faisal Specialist Hospital in Jeddah, where MRSA was reported to be 50% compared to the whole Staph aureus isolate. But I think we get a number lower than that. MSSA therapy, I think it's quite easy because there has been a consensus that the preferred treatment option is cefazolin or anti-staph beta-lactam. But if we want to ask which one is better, probably this systemic review was trying to answer this question, and cefazolin has been associated with lower 30 days mortality and also nephrotoxicity. We are uncertain whether cefazolin or anti-staph beta-lactam differ in terms of treatment failure or relapse, and probably both of them are the same while treating endocarditis or abscesses. Clinically, if you get a patient with Staph aureus bacteremia, what do you need to do? Definitely nothing replaces thorough history and physical examination. And then repeating blood culture is always an essential step because you need to define whether it is a persistent bacteremia or non-persistent bacteremia. Among the minimum evaluation to do transthoracic echocardiography, and infectious disease consultation has been shown to improve the outcome with Staph aureus bacteremia. There are some additional evaluation, which is only limited to those who get higher risk for complication, including TEE and further radiological imaging. I will skip the antibiotic part, but I cannot overemphasize on the importance of source control, which has been always shown to be very important and sometimes more important than the appropriate antimicrobial. So, hearing the previous slides regarding the Staph aureus bacteremia, it's highly fatal disease. Is it always complicated? And the answer is no. Not all the cases are complicated, but you get a certain definition for non-complicated, which is mainly you doesn't have persistent bacteremia and there is no metastatic infection. And here is the list of definition of uncomplicated. There is no central line, and if there is one, it has to be removed within 5 days. Non-persistence, resolution of the fever and symptoms earlier. I think it's always important to know ahead what is the percentage of those who get complication. Unfortunately, we don't have that good answer because of the variation in the numbers, whether related to randomized control trial or observational studies. And the numbers are actually as very variables, ranging between 9% up to 60%, but probably the percentage is something around 40%. But it's more important, actually, to know what are the risk factors for getting complicated Staph aureus bacteremia. I like all of those circles. It does look nice, but the point here is the gray circle represent the complicated Staph aureus bacteremia. And here are the list of different risk factors. And you can see the overlap between the risk factor and the complicated Staph aureus bacteremia. So for example, you have 166 cases of community acquired. Among those, 129 had been complicated Staph aureus bacteremia, which is, I think, around 70 to 80%, which means that community acquisition definitely is a risk factor for complicated bacteremia. The other important risk is persistent bacteremia, which has been correlated to odds ratio of around 7, and also presence of prosthetic material. There has been an update for the definition of complicated bacteremia since it was introduced in 1998. I think it's just a more elegant way of listing the risk factors for complication by having it into groups or subheadings, like predisposing cause factor, features of bacteremia, and clinical course. the majority of those risk factors has been listed in the previous definition. But however, this definition aimed to risk stratify patients into higher risk, which need further evaluation and definitely deserve to have a longer duration of therapy. I want to point for this important risk factors, which has been shown to be a very important predictors of complication of Staph aureus bacteremia. The persistent bacteremia, but you have to pay attention that in the literature, there have been different definitions for what is the persistent. Sometimes it's more than 3 days, 7 days. But in this study that was published in 2007, actually they picked more than 7 days compared to less than 3 days, which is non-persistent. And you can see the significant difference in mortality. Those patients who get persistent bacteremia, their mortality was 27% compared to 12% in those who get non-persistence. So is there a difference between MSSA and MRSA in terms of mortality? Probably yes, based on this meta-analysis, which showed a significant increase in mortality associated with MRSA bacteremia that was found in majority of the studies were involved in this systemic review or meta-analysis. I was asked to present some of the difficult cases, and I believe all of you have been previously exposed to cases of Staph aureus bacteremia. But actually, we published or reported our experience with MRSA, which was mainly using ceftobiprole. Among the 6 cases that ceftobiprole have been used, actually the majority of them get favorable clinical outcome. And for example, the first patient who was an 18-year-old male who was admitted with febrile neutropenia, the underlying hematological malignancy was large B-cell lymphoma. So ID was consulted because of the febrile neutropenia. The blood culture grew MRSA, the MIC was 0.5. The line was removed because of the anticipating that it would be a complicated bacteremia. Ceftobiprole was added for 2 vancomycin. The patient was complaining of some respiratory complaints. CT chest was done, and it showed multiple infiltrate, which is likely compatible with having invasive pulmonary aspergillosis. The blood culture cleared. TEE was negative. The patient improved. And after 2 weeks of therapy and starting of ambisome, the repeated CT chest actually showed nearly complete resolution of the all finding, and the patient was doing well. Another example was an elderly male who was paraplegic after a road traffic accident, presented to emergency with fever and back pain. His blood culture grew MRSA. He was in the ICU because of hypotension. Again, vancomycin was combined with ceftobiprole because of the severity of the disease and anticipating that he get vertebral osteomyelitis, which was the case. Blood culture cleared. The patient get also both clinical, radiological, and microbiological resolution of all of the symptoms. So I think generally why it's difficult cases when we are dealing with Staph aureus bacteremia, because what is related to high mortality of Staph aureus bacteremia, possibility of getting endocarditis, and also there are common scenarios that we are facing when treating Staph aureus bacteremia, including the persistence of bacteremia, persistence of fever, failure of therapy, having different metastatic infection, and even after completing treatment, sometimes relapses or recurrence of the disease. Now I would move to the second part, which is what is the available therapy, but here limited only for MRSA, not for MSSA. So probably the most commonly known and used medication for MRSA is glycopeptide, vancomycin, lipopeptide. An example of that is daptomycin, lipoglycopeptide, beta-lactam, which has different antibiotics that has been used, which initially anti-staph, beta-lactam, anti-staph penicillin, or cefazolin has been used in combination. But here what is listed is the 5th generation cephalosporin, which has an activity against MRSA, which is ceftaroline and ceftobiprole. Other medication to treat MRSA is linezolid, Bactrim, and probably rifampicin aminoglycoside has been used only as a combination therapy. It looked very simple. You need to pick one of the medication or a combination. And if the combination were selected, which combination that you should go for. But unfortunately, it's not really that easy. It's a little bit complicated. But let's get some history. So Staph aureus initially was all MSSA till 1960, where we started to identify and isolate MRSA, which was mainly related to healthcare associated. That was the case up to 1990s or 2000, where we have a community-acquired MRSA. Within the same line, there have been an evolution of the therapeutics. So glycopeptide vancomycin was discovered in 1958. Then the landmark trials of daptomycin has been in 2006. We get the novel cephalosporin talking about ceftobiprole and ceftaroline in 2010 and 2008. And lately we have the combination therapy. So ceftaroline was the older medication that was getting an FDA approval in 2010, and it was approved for skin soft tissue infection and community-acquired pneumonia. However, ceftobiprole was later introduced in 2018, and it has an activity against MSSA and MRSA. But this is very recent update that last month, ceftobiprole was approved by FDA to be treatment for Staph aureus bacteremia, including endocarditis. So I will try to list the important studies included in the treatment for MRSA. And I think there is no more important study which changed our clinical practice compared to this study that was published in 2006 in New England Journal of Medicine, where daptomycin was compared to standard of care. So 124 patients with Staph aureus bacteremia with or without endocarditis were randomized to receive daptomycin, and another 122 patients were randomized to receive the standard of care, which was vancomycin for MRSA, and it was anti-staph penicillin for MSSA. Both of them were combined with gentamicin. The outcome was the success at day 42, and actually daptomycin was non-inferior to vancomycin, as the success was reported to be 44% in daptomycin compared to 41% in the standard of care. However, that was actually not consistent in all of the subgroups, including MSSA, where daptomycin was inferior to standard of care, and also endocarditis. Without digging deep into analyzing that study, I think there are a few points which need to always to take in consideration before getting any conclusion. That the study included only subgroup of MRSA, it was only 38%, and we know definitely that cefazolin, anti-staph beta-lactam of penicillin, actually is superior than daptomycin. Pneumonia were excluded, and only 50% of the cases actually get complicated bacteremia. Gentamicin was administered to nearly all of the patients of standard of care, and that was resulted in higher side effect and stopping the medication and failure of therapy. But not only that, actually daptomycin was associated with higher microbiological failure, clinical failure, or both. It was 19% compared to 13% in standard of care. In addition to that comment, actually there is an editorial comment regarding the study, including that it was an open label study, but also only 29% of the patients initially thought to have endocarditis get a confirmed diagnosis at the end that this is endocarditis, and that resulted in that the study population was heterogeneous. I would agree with the same conclusion that daptomycin may be cautiously considered as a potential treatment option for some of the patients with Staph aureus bacteremia. So for me, it's not really that conclusive evidence regarding using daptomycin, particularly for MRSA, owing to the microbiological failure mainly and limited generalizability of excluding pneumonia. 17 years later, actually, the new medication at that time became old, And now the new medication, which is ceftobiprole, is compared to the old medication, which is daptomycin. In this phase 3 double-blinded, double-dummy, non-inferiority trial in patients who get complicated Staph aureus bacteremia, whereas the primary outcome was overall treatment success 70 days after randomization, and ceftobiprole has been shown to be non-inferior to daptomycin. The complicated definition at this trial was Staph aureus bacteremia as persistent, which is positive blood culture despite receipt of the appropriate antibiotic for 3 or more than 3 days before randomization, and Staph aureus bacteremia associated with hemodialysis or other focus of infection. Just to note that left-sided endocarditis were not included, and the right-sided endocarditis was 6.5% among the total population included in the trial. So ceftobiprole was non-inferior in terms of efficacy and also safety as shown here. And that was consistent among all the outcomes which were listed, including death, which was around 9%. So another thing also to note or to comment that the daptomycin dose in this trial was 6 milligram per kg, and there is an option for the treating physician to go with higher dosing, to go with 10 milligram, but unfortunately there was no subgroup analysis for higher dosing of daptomycin, and I think you noticed that the low mortality, which was reported, which was around 9% compared to the real life data, which is definitely much higher than that. Let's move from ceftobiprole, but this time with the other cephalosporin, which is ceftaroline. So in this multicenter retrospective observational cohort of patients only who have MRSA bacteremia, they were compared for having a composite of treatment failure. And ceftaroline compared to daptomycin actually was non-inferior in respect to the composite failure. As you can see here, the ceftaroline was associated with lower failure rate of 32 compared to 39%, but it was associated with numerically higher number of death, which was 14.5 compared to 10.7, although it was not statistically significant. But one of the very important limitations in such retrospective data, particularly this type of the study, that the study therapy, whether daptomycin or ceftaroline, was not the initial therapy that has been used for those patients. And we are not really quite sure whether the similar result would be if we used ceftaroline or daptomycin as the initial therapy. What about if you get a patient who started initially on vancomycin, but after that you decided that daptomycin probably is better and you switch to daptomycin? That was actually the question or the objective one to be answered by this observational retrospective data to evaluate the effectiveness of switching from vancomycin to daptomycin compared to remaining on vancomycin. So among those large number of patients who were receiving vancomycin for MRSA, 7,411 patients, only 1.5% switched to daptomycin within 3 days of starting vancomycin. And such a switch actually was associated with lower 30 days mortality and hazard ratio of 0.48. However, those patients who were switched early were higher likely of having vancomycin MIC more than 2, getting renal replacement therapy, and also getting an ID consultation, and also receiving a combination therapy with beta-lactam, particularly ceftaroline. It's definitely very trendy now to get an oral option for treatment, and Staph aureus is not an exception, where this randomized control trial, which assessed the efficacy and safety, early switched to oral therapy only for non-complicated Staph aureus bacteremia, which included 8% of MRSA. The oral option was shown to be actually non-inferior to continuing intravenous treatment in their composite primary endpoint, which was occurrence of any complication related to Staph aureus bacteremia. If you're asking about what was the oral option, it was Bactrim, for MSSA and MRSA, clindamycin for MSSA, or linezolid for MRSA. Now let's move to higher level of evidence of systemic review. I picked two systemic review. The first one, which was efficacy and safety of vancomycin for treatment of Staph aureus bacteremia, because it has been defined as a standard of care. And the other one is comparing daptomycin versus vancomycin for an isolate with higher MIC. So this systemic review that was published last year included 15 randomized controlled trial and 9 retrospective data, and they concluded that the efficacy of vancomycin in treating Staphylococcus aureus bacteremia is still excellent, but slightly inferior due to adverse event. If you want to compare vancomycin versus daptomycin, so vancomycin showed lower microbiological cure rate and clinical cure, as well as more adverse event. In terms of mortality, actually vancomycin had a lower mortality compared to the other comparators that were listed. But I think this is very clear example of systemic review and meta-analysis of comparing apple to orange, because lumping MSSA and MRSA together probably is not really the best thing to get a conclusion related to MRSA. And unfortunately, some of the data which was referenced as randomized controlled trial shown to be a retrospective cohort case control. So definitely it would be questionable validity to take a conclusion out of that systemic review. But one of the evidence of superiority of daptomycin compared to vancomycin was this study, that all of MRSA bacteremia retrospectively were included in matched cohort based on the age, pet bacteremia score, and primary bloodstream infection. 131 patient in vancomycin group compared to 131 patient in the daptomycin. So the daptomycin actually was superior in terms of all of the primary endpoint, which was clinical failure. Daptomycin in black was associated with less composite failure, less persistent bacteremia, less change in therapy, and less 30 days mortality. But look to this discrepancy between the automated testing system for MIC for vancomycin compared to the standard of broth microdilution. So the MIC of 2, 60% of the isolate based on the automated was having an MIC of 2 compared to only 7% in the standard of broth microdilution. Not only that, 80% of the patients started in vancomycin before switching in daptomycin, which is definitely limiting the conclusion of superiority of daptomycin. But probably, which is very clear, and there is a consensus in the literature about it, that superiority of daptomycin compared to vancomycin with having a higher MIC for vancomycin. And in this systemic review and meta-analysis, including vancomycin MIC more than 1, daptomycin was superior to vancomycin. Other interesting evidence, probably if you are female, it's not really a good news, because the risk of mortality with Staph aureus bacteremia is higher, and I'm feeling sorry for that. Okay, I hope that you are still interested to the last part of this presentation about my own approach. So I would prefer to have a combination therapy for complicated MRSA bacteremia. And as a plain language, if monotherapy would work, which has been shown in ceftobiprol's study, randomized controlled trial, so I think combination with using a beta-lactam, which has an activity in vitro against MRSA, it would work. But still the question, which combination and for whom and for how long, that need to be answered. But being on the other part of the debate and why not combination, a lot of people would argue that there is no strong evidence of using combination. Particularly, there was no RCT documenting the superiority of combination. And definitely, when you're getting a combination with adding another medication, you are aiming for having side effect and possibly collateral damage related to the combination therapy. There have been few evidence in literature trying to answer that question, whether combination therapy would work or not, or combination therapy to be or not to be. And here they are against actually getting a combination. And based on their statements, clear that additional antibiotics are associated with harm and less clearly that it will lead to any benefit. They had an example of aminoglycoside and rifampicin. And for now, they think that clinicians should follow what have been established as best practice for Staph aureus bacteremia, get an ID consult, perform evaluation to find and control metastatic site of infection using beta-lactam for MSSA and vancomycin or higher dose of daptomycin for MRSA. By the way, this report was published in 2019. Until we get more evidence documenting that combination therapy is superior. But let's try to explore the evidence more. And that was another review in 2021, trying to answer the question, what do beta-lactam add to vancomycin or daptomycin in the treatment for only MRSA? So I think, the initial evidence was to get a combination of cefazolin or anti-staph beta-lactam, and that was based on in vitro studies, which was very promising that it has higher efficacy to go with the combination therapy. Also, that was shown in a pilot trial, but probably Camera 2 trial actually get more conclusive result that combination therapy of vancomycin or daptomycin combined with anti-staph beta-lactam or cefazolin was associated with higher mortality, and probably it's not really wise to go with such a combination. But what I'm suggesting or want to have a better review or evidence regarding it is exploring the fifth generation cephalosporin, which is ceftaroline or ceftobiprole usage as combination therapy. This is one of the pilot trial which showed that combination therapy was better actually than the monotherapy. There was no other randomized controlled trial apart from that pilot trial, but there are other observational studies only for ceftaroline, but not ceftobiprole. But not all of them are relevant enough to answer our question regarding combination with ceftaroline. For example, those two studies actually included a lot of other combination with beta-lactam, mainly with cefepime. And also there are other limitations which related, for example, of the design or the inclusion criteria of studies. For example, this study actually included both arms. Patient received ceftaroline as a combination, or it was limited by their inclusion criteria for only limited population like septic pulmonary emboli for the first study. But let's get over the evidence. So I think this is the most referenced study whenever talking about combination therapy with ceftaroline. Although it was a pilot trial, only 40 patients, but actually the result was very significant and the study was terminated early. So look to this significant difference in mortality between the combination therapy and monotherapy. None of the patients who were 17 patient combination therapy died compared to 30% of the patients who get monotherapy with vancomycin or daptomycin died. Because of that, the study was terminated early, but it's definitely suggesting that the combination therapy is superior to monotherapy. Other study, again with the combination with daptomycin and ceftaroline, although it was a retrospective, but it was matched cohort based on the patient age, bacteremia source, and renal function. And the outcome was clinical and microbiological outcome. And let's take a look into the result. So 58 patients were included in daptomycin and ceftaroline combination compared to 113 in standard of care, which was vancomycin or daptomycin. And look to that significant difference in the mortality. 30 days mortality was 6.8 in the combination compared to 14.2% in standard of care. Also, microbiologically, combination therapy was better as the relapse or recurrence was 8.6% in the combination compared to 9.7% in standard of care. But not only that, actually those patients who were included in combination, actually they get a higher risk for complication evident by the duration of bacteremia, which was 9.3 days in the combination compared to 4.8%. So actually combination therapy was better, but not only that, for patients who get a higher risk for complication. And they concluded that receiving daptomycin and ceftaroline earlier in the infection course may be more beneficial for survival. Coming to more studies, although less important, this retrospective data comparing monotherapy versus combination with a composite outcome, which was mainly related to clinical failure. And it showed that combination therapy actually was associated with less clinical failure, but higher 30 days mortality. But I think it wouldn't be really very good to take a conclusion out of the study, knowing that around more than 75% of the patient in combination arm, the combination drug was cefepime or cefazolin, and only 12.2% were the combination of ceftaroline, which is our interest in this review. So there are also other less important trials. For example, this retrospective data on those patients who get persistent bacteremia, but they included all the patients who receive combination. But their question was whether to continue on ceftaroline after the bacteremia clearance, or you would continue on that. And actually, there was no difference. So the monotherapy, which was labeled as monotherapy, actually was a combination. Ceftaroline was begun within 4 to 11 days of the refractory bacteremia and the median of 6 days. And there was no difference in the outcome. And the last study was only limited to those patients who get septic pulmonary embolism. And they found that daptomycin monotherapy was found to have a comparable success compared to the combination therapy. Not to forget that the combination is only limited for MRSA. It's not for MSSA. This systemic review showed that the combination did not decrease in mortality, but also was associated with higher side effect. Definitely, we should not forget to include CAMERA-2 trial, which addressed the vancomycin daptomycin combination with anti-staph beta-lactam compared to the monotherapy. And the study resulted and showed that the mortality rate was higher in the combination group compared to standard therapy, and the study was terminated early due to that and to adverse event. So finally, my conclusion out of that, I will quote this conclusion of this editorial, which think that early combination therapy offer advantage over monotherapy. I would believe that the combination therapy would perform better compared to monotherapy, but not for the all patients. Definitely only patients who get high risk for endovascular infection. Definitely not vancomycin with anti-staph penicillin. I would go with the combination, which is most commonly has been used, which is daptomycin plus ceftaroline. But does that mean that vancomycin and ceftobiprole wouldn't work? Probably all of them would work, but definitely we need more study to examine the difference between both arms in terms of efficacy, safety, and probably pharmacoeconomic advantage. All of that conclusion was based that standard of care currently needs to be improved. And definitely there is no one size which fits all. And because of that, the combination would be limited only for high risk population. But however, there's still an unanswered question regarding the duration for combination therapy. Their algorithm for treating of Staph aureus bacteremia is as following. So whenever you get gram-positive cocci and cluster in the blood culture, you have to see that whether it's related to pneumonia, and you will go with monotherapy, linezolid, or ceftaroline. If it's skin soft tissue infection, you will go with vancomycin or daptomycin. All of those are related to patients who get low risk. However, it tend to be higher risk patient. They will go with the combination therapy with those options of combination therapy. So if the patient get also with persistent bacteremia, you would continue on the combination until the patient is better, the bacteremia is controlled and clear, and following that, they will go with the maintenance therapy of vancomycin for 4 weeks. For me, I think MSSA is quite easy, and you will go with cefazolin. Definitely, we cannot overemphasize the importance of always doing source control. I would pick vancomycin unless there is an acute kidney injury or there is a higher MIC for vancomycin, because there is very strong evidence in literature supporting that daptomycin is superior to vancomycin in such a situation. If it's not complicated, probably it doesn't really matter, and probably the available treatment option wouldn't be different. However, if there is a high suspicion for complication, namely endocarditis, prosthesis, I would consider having a combination. The question is which combination? I think daptomycin or vancomycin, any one of them, plus again, any one of the 5th generation cephalosporin. If there is a lung involvement, you shouldn't use daptomycin, because daptomycin will be inactivated by surfactant, and there is always a room for oral option. So I would agree with similar algorithm related to the previous slide. However, I will go with the combination of daptomycin plus ceftaroline. And probably the unanswered question, if the patient improves, which is definitely a good thing, but what to do next? Whether to continue in vancomycin, to continue in daptomycin, or to continue with only the 5th generation cephalosporin, probably that need to be answered. By that, I'm concluding my presentation. I hope that you enjoyed this talk. Thank you very much.